My name is Professor Goran Stankovic. I'm interventional cardiologist from Belgrade, Serbia, and the board member of the European Bifurcation Club. It's a pleasure and privilege for me to participate in the Abbott-sponsored symposium, and my task is to discuss why imaging is important in treatment of coronary bifurcations and why we should go beyond classical guidance with coronary angiography. If we discuss PCI in 2022, I think it's clear that complexity of PCI continuously increases. And if you look this complex anatomy of the left main bifurcation plus diffuse disease of LAD and circumflex, we understand why guidance with conventional angiography could be misleading because it's just three-dimensional vessel structure represented in angiography with two-dimensional appearance. Of course, we also have risk of overlap for shortening, and we need to take multiple projections. We don't get data on angiography regarding plaque composition, plaque distribution, and of course, there is no additional information on the physiological significance of the lesions in both main vessel and the side branch. And even when we optimize procedure with the angio guidance, we don't have information about potential residual ischemia in both territories, about stent under expansion deformations, malapposition of the struts, and of course, residual plaque burden, plaque protrusion inside the stent, as well as the presence of edge dissections. We are advocating people in bifurcation PCI to learn certain steps of the provisional. And I'll just give you this example of the left main crossover stenting. You see main vessel stent from the left main into the LAD, and you see our attempt to recross into the circumflex through a distal cell. Because if we go in the distal cell, we will be able to scaffold the ostium of the circ and decrease the need for stenting of the circumflex. From this image, we have impression that it's probably centrally or distally, but we don't know in which cell we are crossing. And then we do OCT and look here, it's not proximal or distal, it's actually completely outside of the stent. We are crossing into the circ outside of the stent because a position of the stent inside the left main is suboptimal. And I really thank you, Yoshio Numa, for this excellent video, which really convincingly tell us that using OCT really provides critical, important additional information in order to plan and perform complex PCI in 2022. And we have some data from the registries which are very convincing. For example, these are the Kaplan-Meier curves from the Pan-London PCI registry, large registry, 75,000 procedures, in which you see 5-year mortality, which is significantly higher if we guide procedures by angio compared to guidance with imaging, both IVUS and OCT. And if we go comparison OCT guidance versus angio guidance, we have clinically relevant, statistically significant reduction in all-cause mortality. Also, data from Francesco Prati, CLIO PCI, shows you that OCT guidance is associated with significantly lower risk of hard endpoints, cardiac death or MI, driven, as you may see specifically, by reduction in the cardiac mortality. So imaging is good, imaging improves clinical outcome, but what is the reality? Here are the most recent data that I could find coming from British Cardiac Intervention Society data 2017-2018. And you see in more than 100,000 PCIs, use of imaging of OCT was less than 3%. So it's somehow important to understand that we have very important added value of guiding procedure with imaging, both IVUS 8%, OCT 3% of cases. So in total, 11% of procedures nowadays are guided in British Intervention Society database by imaging. And it's also the survey from EAPCI that confirms these findings and really showing in green percentage of operators and centers in the regions. And we understand that 15%, which is green, only 10% of European population of interventionists is using imaging in more than 10%, 15%. In Japan, we have completely different picture. 97% of procedures are image guided. And of course, it's very important to see the other question, how it goes with the experience. And we see that by increasing experience, experienced operators realize the value of image guidance and the impact on hard clinical outcome data. So operators with more than 5 or more than 10 years of experience are more and more using imaging. So for operators with more than 10% of experience, 60% of procedure of them uses imaging on a regular basis in more than 15% of patients. What do the guidelines say? We have upgrades, and we are expecting even more and more as data are collected for both imaging modalities, for imaging with IVUS or with OCT. And we have for OCT, for stent optimization, increase from class 2B to class 2A regarding the selected patients to optimize stent implantation. Then we have also recommendation for IVUS to assess the severity of unprotected left main lesions, but optimization is maybe too late. So we need to start planning procedure from the very beginning based on image guidance, based on view from inside the plaque, instead of just having imaging endorsed procedure. Actually, when you finish optimization, you do final imaging just to confirm stent apposition. I believe it's much, much better, much, much more useful to start from the very beginning, assess the lesion, plan the strategy, guide the procedure, and optimize result. In such case, we will really reach the full benefit. Of course, imaging is critically important to detect stent-related mechanical problems which lead to restenosis. And the general complex of intracoronary images are well underlined in 2 expert consensus documents designed by EAPCI. So we see certain stent areas, more than 5.5 square millimeter on IVUS, more than 4.5 square millimeters on OCT, then expansion index more than 80% if we want to make sure that we improve clinical outcome of our patients. Here are the data which show us from Stefano Group that if we use imaging from the very beginning, pre-intervention, it will help us in 82% of lesions to change the strategy, to change the decision based on what we see, because pre-intervention, we can see lumen size, vessel size, we can select optimal device sizes, both for balloons, for stenting, we can select the landing zone, having the risk of complications, presence of TICVA, stent diameter, which is really optimal. And by doing that, we actually, in 4 out of 5 patients, change what we would do based strictly on angiography. Plus, after the procedure, throughout the procedure, we have any change based on OCT in additional 50% of lesions, and it's predominantly, as expected, key issues: stent expansion, stent apposition, and stent distal edge or proximal edge dissection. So these are the key informations which I think we should keep in mind in order to understand why OCT guidance is good for our patients and is good for a real long-term impact on the clinical endpoints. Abbott, with the Light Lab workflow, is trying to promote all this knowledge and all this experience in the workflow named MLD Max algorithm, which actually tells you what is the reason to use prospectively full range of information from OCT regarding pre-PCI, during PCI, and after PCI decision making. So pre-PCI pullback can help us, of course, physiologic assessment, but most importantly, morphology, length, and diameter of the lesion. Then we can plan strategy. During the procedure, we have possibility of angiographic co-registration to make positioning much simpler. And final pullback with IVUS, post-PCI pullback, should tell us if there is a presence of medial dissection, stent apposition, and stent expansion. And this algorithm, MLD Max, really tells you how we are trying to integrate all the available knowledge into the algorithm to get maximum clinical benefit from the use of procedural guidance with imaging from the beginning throughout the procedure until the end. And there are some quantitative measures which are, of course, subject to change. We believe that we will collect more information, and in the future, this will become integral part of artificial intelligence in the next software generations. So we will make sure that by using this software, we can really assess presence of calcium from the beginning, quantitatively assess it more than 180 degrees, thicker than 0.5 millimeter, longer than 5 millimeters. So we will get suggestion from the first pullback before procedure, whether we need specific devices for lesion preparation and how to plan the strategy based on the findings. Pre-procedure, what is the length, what are the safe landing zones, and which diameter we should safely select to achieve optimum. At the end, we exclude medial dissections, and we are sure that we have optimal apposition and we have achieved optimal expansion criteria. Together with Japanese and Korean Bifurcation Club, EBC has published series of documents in which we try to specifically advocate how to use imaging in bifurcation PCI. So pre-procedure, we believe it allows optimal selection of devices and defining optimal PCI strategy. So we measure dimensions of lumen, vessel in both branches, main vessel, side branch, assess atherosclerotic plaque morphology, plaque burden, longitudinal distribution, presence of calcium, and negative vessel remodeling. We can detect angiographically silent disease, but of course, we can also in a cut plane estimate the risk of the side branch compromise. Optimization of the procedure allows stent apposition, stent expansion, full lesion coverage, presence of dissection, plaque prolapse, side branch residual stenosis and dissection, and during the procedure, key component of the OCT guidance, 3D OCT, optimal guide wire recrossing into the side branch in order to remove jailing struts from the side branch ostium. And we learn in the optimum trial, which is a randomized comparison and assessment of incomplete stent apposition at bifurcation site, if we do 3D OFDI guidance versus angio guidance, we see significant superiority of 3D imaging to guide optimal distal recrossing in bifurcation segment stent apposition. Here is our schematic presentation, how we envisage OCT-guided provisional stenting. So we should do first imaging in the beginning, after recrossing, and if it's necessary, predilatation of the main vessel. Second OCT run after POT to assess expansion, apposition, deformation, exclude dissection. And finally, when we finish procedure, final imaging with post-dilatation, final kissing balloon, and repot. I'll show you case example. You see 60-year-old male, stable, Canadian class 3, STEMI, inferior wall, treated at that time with in September 2020, treated with primary PCI, and this is now evaluation and intervention of this diffuse disease in the left coronary artery. Imaging, and you can see here pointer showing you exactly on the angiography at which segment is a disease that you see on the OCT run. So a lot of tissue, some calcium, diffuse disease distally, distal to this big second diagonal branch. Then when we come closer, vessel improves in significant diameter, good lumen area, less disease, again some calcium, and then we approach with this pullback more proximal bifurcation. In that bifurcation, again, tight narrowing, a large plaque burden, not that much of calcium, and then we approach proximally the left main, and we see clearly that while approaching now the left main, we have significant disease throughout the LAD, significant disease and tight narrowing here at bifurcation site, and disease which is significant with low area inside the left main. So the whole segment needs to be treated, but we know that reference for the LAD proximal is around 3.5 millimeters, distal is 2.6 millimeters. We start treatment from distal to proximal. Predilatation stenting distally, Zion Sierra 2.5 by 28, POT 3.5 safely based on OCT. We can expand 2.5 to 3.5. I think very important message for all of you, expansion capacity. If you use Zion Sierra, sizes from 2 millimeters have the same device platform to 325, and you can safely expand 2.0 to 25 up to 3.75, preserving the structure. This is repeat imaging. After distal stenting, you see angiographically looks much, much better, but some intermediate disease present. And if we assess stent apposition, we still have minimal stent area of only 2.7. So we need to do distal optimization, distal to bifurcation. And this is NC balloon 2.5 by 12. High pressure, and angiographically you clearly see the improvement. And then second stent, long Zion Sierra 3.5 by 38 selected, covering from the left main, a disease segment of the left main, up to proximal part of the LAD, and then inside the left main POT with 5.0 balloon. Again, important data, 3.5 Zion Sierra can be safely expanded up to 5.5 millimeters, so 2 millimeter bigger balloon. And this is interim result. We are not sure about the result at the ostium of the circ. So kissing was performed with repeat final balloon and final OCT, which clearly showed something surprising angiographically, not visible distal dissection, but here on the OCT we see distal LAD has dissection, so we need to add another stent. And then when we look, we see area of expansion of 76%, so we need to expand and post-dilate more, and much better expansion in the proximal LAD and inside the left main. So still in the dissection, look how easily Sierra flows through implanted stents distally, 225 by 18, covers the distal segment, and this is, I'm sorry, final optimal angiographic result. Final OCT shows stent area 13 millimeters in the left main, 9 in the proximal LAD, 7 in mid LAD. When to use imaging in bifurcations, in addition to this guidance, we can use it to assess stent failure. And this is our case from our cath lab, acute case, isolated ostial LAD lesion regarding bifurcation, and clear circumflex tight distal lesion. Operator decided to stent precisely ostium of the LAD without left main stenting, and scheduled procedure in the circumflex for the second PCI. This is staged procedure, but when we saw this angio, we had suspicion that stent in the ostium of the LAD protrudes in the left main. Use of OCT showed us good expansion in the LAD, but also a long 4 millimeter protrusion of the floating struts of the stent from the LAD into the left main. So this is the OCT evaluation. And we see here overhanging struts in front of the ostium of the circ, which complicates procedure in the circ. And also on this image with number 1, we see both two wires. So wire which I wanted to put into the circ, I documented by OCT that it's positioned inside the stent. So what was the idea? This is the protrusion, floating struts in front of the ostium. Idea was to use wire through the stent struts, oppose appropriately strut inside the left main, and then cross over to double kissing culotte and fully expand both stents in the distal part of the left main. So these are the steps. First, pot, then opening of the struts, first kissing balloon inflation. After we open struts towards the circ, distal circumflex, direct stenting, and after that, second stent, high pressure, individual balloon inflation, and the final pot. This is the third pot, and this is final angiographic result optimally, and we confirm optimal result also after additional pot with 5.0 NC balloon inside the left main, and you see fantastic expansion of 103% inside the distal left main. And in the analysis, we see adequate stent expansion and the position in the polygon of confluence with minimal metallic neocarina with central position. We were able, for sharing this, to publish in JACC Interventions last year, and I congratulate Dr. Milashinovic for putting this together. Finally, 3D OCT, just the advantage. So advantage of 3D OCT, measurements of the side branch ostium when you perform main branch pullback, and in the cut plane you can evaluate the side branch. Then you can use to cross distally instead of proximally and make sure that you achieve optimal distal recrossing, and with kissing removal with kissing balloon inflation in case of link-free type. However, if we see this link, we know in advance that even after kissing, we will not be able to fully clear the struts from the ostium of the side branch. So we need to try to recross and use different branch. And the final, just an example, after single crossover, it was impossible to cross distally with balloon in order to perform final kissing, not possible to cross the main vessel. You see OCT was done, and on 3D OCT, you see the wire in the side branch, first inside the stent, but then underneath the second strut. So this is why balloon was stuck here. So we had to rewire and finish easily with final kissing. So dear colleagues, my key messages are that intravascular imaging improves clinical outcome. OCT provides high definition visualization of plaque and stent during PCI. There is growing evidence that imaging should lead to stronger recommendation in the guidelines and consensus documents. Accurate assessment of main vessel and the side branch before, during, and after the procedure are extremely important for stent optimization in complex bifurcation PCI. OCT has impact throughout the procedure, and we await results of the Illumian 4 in October to collect data to confirm the benefit of OCT guidance on hard clinical outcomes. I thank you very much for your attention, and I'll be happy to take all your questions. Thank you.
Hi, Goran. Thanks for these excellent presentations and for your participation, remarkable participation at our course.
Thank you, Gelev.
Questions and comments from from the audience, from the panel?
Goran, how frequently you use OCT?
But you know, it's not the rate which determines the need to use OCT. It's actually available data that we have that use of imaging is always helpful. I cannot use as much as I wish because, as you probably know, in Serbia, it's not reimbursed. So the cost of image catheters as well as the cost of FFR pressure wire is my own cost. There is no reimbursement from the government for using these very useful and guideline recommended devices. But I try to use it regularly for left main PCI because I think the biggest advantage that I can have is using imaging to optimize result of the left main PCI. And of course, as you saw, it's really recommended to use it when you have diffuse disease. According to my experience, but also according to some data from Clio PCI and the other registries with OCT, Francesco Pratti group, the most of the value is actually to start using imaging up front. When you see angiogram, you can be biased by the presence of calcium, by real assessment of vessel diameters, plaque distribution. And when you do imaging, you get surprised how many new additional informations from the pullback of OCT after wiring left main LAD you can get. And that helps you really simplify the procedure. With the co-registration, you can really see clearly on angiography what are the reference points, which device size you should use, balloons and stent as well, what is the length which is the most appropriate, and even positioning of the stent becomes critical because you can clearly in advance assess if you have 10 millimeter of stent proximal main vessel inside the left main in order to safely perform POT. So I cannot say that it's extremely frequent. It's probably in our database in the range of 5 to 10% together OCT and IVUS. But most of the complex cases, I can guarantee, in our cath labs is done by image guidance and physiology, if necessary, mainly after main vessel stenting to assess physiologic significance of the jailed side range. If you see that circumflex has a carina shift or combination plaque and carina shift after stenting left main crossover, with FFR you can really assess physiologic significance. So I believe there are multiple clear benefits of using physiology and imaging, but in the reality, meeting like yours can help sharing that information and giving personal perspective and experience. And we have really convincing data already published that use of imaging is always going in positive direction and improvement of outcome. And we are waiting October and Illumian 4 to have adequately powered randomized data to show the benefit of imaging. Sorry, I become very passionate when I speak about importance with all the restrictions of real life use of imaging.
We typically have the same problem and we share your
Emotions.
excitement, yes. Do you have any issues with imaging of the osteal part of the left main, which seems to be, let's say, a disadvantage of OCT compared to IVUS?
Yeah, thank you very much.
How you overcome this?
Yeah, this is great question. There are obstacles in using OCT for the assessment of the osteal part of the left main, but in most of the documents, we recommend OCT to guide bifurcation, left main bifurcation PCI, in which you can really clearly benefit from all additional information that you can get from OCT regarding better resolution compared to IVUS. However, if you use extension catheter like the guideliner or telescopy, in the few millimeters of the ostium of the left main. So you go with the guide liner 2 or 3 millimeters inside the left main, and then you are able to flush out, and through the guide liner with OCT you can evaluate also the ostium. But I would suggest, if you have really true distal disease, to use predominantly OCT. If it's diffuse and calcified and you really need information throughout the procedure on the ostium of the left main, then use IVUS instead of OCT. But such kind of experience that you are gaining with time really lets you decide individually. For majority of lesions, I think you can use equally both. And if you need information restricted to the ostium of the left main, probably IVUS is better.
Thank you.
I have a question.
Nikki?
May I ask?
Sure.
Yes.
Yes. Thank you very much. Excellent presentation.
Thank
You
you.
showed the beauty of the OCT images and how detailed these are there. But you showed a case with the dissection of distal edge of the stent invisible angiographically.
Yes.
Do you believe that we should stent or seal all of these invisible edge dissections, visible by OCT but invisible by angiogram?
Yeah, that's great question. Thank you very much. Of course, dissections which are visible by, in this case, OCT, are classified in the guidelines already if they go and penetrate into the media. Medial dissections are one that we are worried could progress to vessel closure. And in this case, this dissection really went deep inside the media, and that was the reasoning behind stenting. Otherwise, as you pointed, if we don't see dissection on angiography, we don't routinely stent every dissection, minimal dissection inside the intima detected by OCT.
Is a comment, the beauty of intravascular imaging, and especially OCT, is because now you can classify distal dissection, edge dissections or not distal only, see whether they needed to be stented according to the clear criteria, which are not that vague otherwise. This is something, in addition, is you can estimate the calcium burden and the calcified plaque with clear length, depth of calcium, and arc of calcium. And this is something that provides you with a clear how to stay steps and guidance where to use and what kind of ablative techniques. This is very important, and this is this is the beauty of intravascular imaging. And just a comment, additional, probably the role of this imaging, intravascular, will increase very much in the future, just trying to detect and probably treat vulnerable plaques, because now we are staying at the, let's say, in the area of plain everyday PCI. But the future is just to detect and probably prevent acute ischemic events that we know it's a very, very, very big problem, because you know that acute coronary syndrome has the mortality of around 50%, even before they get to the hospital, these people. So, thank you, Goran.